This is chapter 35, geriatric emergencies. So, when we're talking about the geriatric population, this is any person that is 65 years of age or older. 65 is kind of the threshold because it's defined by other governmental agencies. So, we just kind of decided to stick with that. It is projected that between 2012 and 2050, that the population that's age 65 or older, so this geriatric population, is expected to double. Geriatrics definitely are a population in and of themselves and have a lot of special challenges for us, especially in the pre-hospital realm, just because they've got a lot of stuff going on. They may have several different chronic conditions. Um, they're on tons of different medications. Their body is aging, so it just doesn't work the way that we expect it to. So oftentimes, um, they don't present in those classic type ways that we expect. So for us, it's important to understand and appreciate how their life is going to differ from us, the things that they take for or that we take for granted that are really important to them, and what them calling us could mean for their life as a whole. Oftentimes, they're scared to call for treatment because they're afraid of losing their independence. So, when we're interacting with a geriatric patient, make sure that you treat them with respect. Keep in mind that we're going to oftentimes be significantly younger than this population. And I mean, think of how you think of even just the grade below you. You have some preconceived notions about those people that are younger than you. Well, if they were to come up and tell you what you had to do and what they were going to do and made you feel like you didn't have a say in the matter, you'd get very frustrated. Try and avoid ageism, which is stereotyping older people, often leads to discrimination, um, like talking significantly louder to those patients because, everybody that's above the age of 65 is hard of hearing. So not true. Um, it's not uncommon nowadays for patients within this geriatric population to be very fit and very active. Obviously, they're not going to be performing at the same level they were when they were younger, but there's marathon runners clear up into their 80s. So don't stereotype all of them. Effective communication is absolutely essential. And it's not just knowing how to get your point across, but making sure that you stay on their level. So, I mean, the aging process definitely makes it difficult because you have changes in vision, hearing, basically all of your sensations. One that we pay particular attention to is pain sensations. And then there's just overall changes in communication like abilities, can be because of dementia or other diseases. Um, so make sure that um, whatever you say to the patient, first off, your first impression from that patient, based on especially what you say, is either going to gain their trust or lose their trust. And when you lose their trust, you are not going to get it back. So, speaking respectfully, making sure that you introduce yourself, um, be aware of how you look and present yourself. You don't want to look like a homeless person that's supposed to show up and help save their lives because they're not going to trust you. Look directly at the patient, make sure that you ensure good lighting. Even patients that have a hard time hearing are really, really good at reading lips if you give them the opportunity to do that. Give the patient a little bit more time to answer. Um, Try and speak slowly and distinctly, but not like offending them slowly. Try and only have one person talk at a time. Ask only one question at a time. Give them some time to answer because sometimes it takes a little bit longer for them to process what they're hearing and then what they're going to say to respond to it. Give the patient the benefit of the doubt. that they're not hard of hearing, and they can definitely ask you to speak up if need be. Listen to the answer that they give you. Make sure that you explain what you're going to do before you do it and give them the opportunity to participate in their own care. Don't talk to them as if they're not there, or talk to their family members rather than talking to them. Oftentimes, they may have a family member that means well, but kind of runs over top of their wishes for what they believe is right for the patient. So common complaints, geriatric basically has their own issues that definitely are not seen in the younger populations. Hip fractures are extremely common, even from a low mechanism of injury type fall. It could still happen. Oftentimes, bones are weakened because of osteoporosis or other types of infections. A simple rib fracture in an 80 or 90-year-old can result in pneumonia or even lead to death. Other sedentary behaviors can definitely lead to pneumonia, blood clots, and then can be catastrophic for the patient as well. Many older patients are faced with their mortality, on a daily basis. They've already lost friends and family members, and they understand what a simple health issue can mean for them, because it may not be simple. So here's kind of an overview of common conditions and then what can actually lead to death in that geriatric population. This is in your book. I'll let you review it more there. Changes in the body, human growth and development. You kind of peak at your late 20s, early 30s, and then it's pretty much downhill from there. Your aging process is going to be accompanied by several different changes, a decline in physiologic functions, especially in like the liver and the kidneys. All of your tissues undergo aging. There isn't one that stives off and the rest of them do great. The decrease in functional capacity of various organ systems is normal, but it definitely can change how a patient responds. Oftentimes, elderly or geriatric population patients can't compensate as well as we would like them to. Age-related changes definitely make it more likely that a patient will experience a respiratory illness. There's overall weakening of the airway muscles, which can decrease your breathing capacity. Your alveoli can become either enlarged, and elasticity decreases, so you can't actually breathe out, or you may have collapsed alveoli, which is called atelectasis, because you don't have the ability to breathe as deeply as what you have before. And then chemoreceptors, which monitor your blood for changes, don't respond as well. And so your body is going to react much slower to hypoxia. For pneumonia, it's an inflammation and or infection of the lung. You can either have it bacterial, viral, or fungal. It's the leading cause of death from infection in the geriatric population. Aging ends up leading to immune suppression, which makes you just more susceptible to getting any sort of infection. But pneumonia definitely is one of the big ones. Management remains the same, but it is less likely that a geriatric patient is going to respond the same way as somebody that's much younger. Pulmonary embolism. This is when a venous clot ends up lodging itself somewhere in one of your pulmonary arteries. Your patient's going to present with shortness of breath, sometimes chest pain. Typically, the pattern that we see with PEs, it's going to be pinpoint pain. It can often be confused with like cardiac, lung, or musculoskeletal problems. Most of those are going to be a little more diffuse in how they're described. So pinpoint tenderness. You're also going to have the shortness of breath. You're going to have low O2 sats that don't increase significantly with oxygen therapy. And for treatment, there's not a whole heck of a lot you're going to be able to do in the field. So high flow O2 and drive, drive, drive. Changes in the cardiovascular system. The heart ends up what's called hypertrophy. That's when the muscle cells end up increasing in size. Remember that the heart actually doesn't add more cells. They just increase or decrease depending on what the heart is doing, because your vessels tend to stiffen and get plaque buildup within them. Your heart has to work significantly harder to maintain cardiac output, which causes the muscles to get larger and larger and larger. You would think that that actually would be helpful, but it's not, because now those cells need more and more and more oxygen, but your heart is not going to be able to keep up with the demand. So you end up getting a lot of extra burden on the heart, and eventually the heart just can't compensate anymore, so your cardiac output is going to start to decline pretty rapidly. The patients are often at risk for that atherosclerosis. You're going to get fat and cholesterol, just kind of collectively called plaque, that's going to build up within the vessel walls. You have an increased risk for forming an aneurysm. So you end up getting a weakened spot within the vessel from being hit by blood over and over and over. Typically, high blood pressure leads to this. And once it breaks, then blood starts to form between the layers of the vessel. And if that ends up rupturing, all of a sudden we have severe blood loss. Blood vessels become stiff, as well as the heart valves. So now all of a sudden we end up with high blood pressure. You can also have impedance of normal blood flow into and out of the heart because everything is much stiffer. Your electrical conduction system goes under severe aging changes, which can lead to different abnormal heart rates and rhythms or dysrhythmias. Venous stasis can definitely help clots develop over time, and often this is going to be because of a sedentary lifestyle. But you also have loss of function in the veins of the legs. When you're healthy, muscular contraction propels blood forward, and the valves within your leg keep that backflow. While those valves end up starting to fail, and so all of a sudden you get backflow within your legs, you get pooling, which can definitely lead to clotting. You also have what's called orthostatic hypotension. So when you go from a laying to a seated to a standing position, your body usually compensates very well to make sure that you don't have a severe drop in blood pressure. Well, those within the geriatric population don't really have that great of a compensatory mechanism. For a heart attack, which is actually called a myocardial infarction, you kind of think about those classic signs and symptoms of, oh, there's an elephant sitting on my chest, super sweaty, pain, nauseous, lightheaded, etc. Oftentimes, geriatric patients won't have this because all of their nerves and stuff, they just don't work the way they're supposed to. So you end up having very different signs and symptoms. Cardiovascular disease, oftentimes it's just going to be pain on exertion, extreme abnormal fatigue. Those kinds of things are going to be more prevalent than those classic signs. And we will continue on in the next video.